Welcome everyone to our webinar today, which is titled Translating the Essential Public Health Functions into Public Health Curricula. My name is Leanne Coombe and I co-host the Professional Education and Training, or PET, working group for the World Federation of Public Health Associations, and I'll be your co-host for this webinar today. As a way of introduction, I'm currently employed as the Policy and Advocacy Manager at the Public Health Association of Australia, and I'm an Honorary Associate Professor with the University of Queensland. I have a background that ranges across professional public health practice in executive management within the government and not-for-profit sectors, as well as an international consultant and as a public health education specialist in academia. The World Federation has a collaboration with the World Health Organization, and several members of our PET working group have been working closely with the WHO on the roadmap project to professionalise the public health and emergency workforce globally. This project involves three main pillars or action areas, namely refining and unpacking the essential public health functions for operationalisation through an integrated and comprehensive approach to public health practice. Secondly, to develop a competency and outcomes framework towards the delivery of the essential public health functions. And thirdly, mapping and measurement of occupations that contribute to the delivery of the essential public health functions, including emergency preparedness and response. In today's webinar, our panelists will discuss the work that has been the focus of the second action area. So that is looking at how we take the revised essential functions from the first area and implement these in education and training through adaptation of the competency and outcomes framework. To set this in the global context and illustrate the reach of the key partners, from an organisational perspective, this work has been led by the WHO, which, as we know, is a UN agency for health consisting of 194 member states across 6 WHO regions. The technical advisory group that has been working on the second and education-focused action area has been co-chaired by a representative from the World Federation, which represents approximately 5 million public health professionals from around 140 public health associations worldwide, and also from the Global Network for Academic Public Health, or GNAF as we know it, which is an alliance of 7 regional associations that represent schools and programs of public health. So the program for today's webinar is as follows. Ataya Masam will discuss how the WHO essential public health functions have been unified and unpacked as part of the roadmap project. Then Siobhan Fitzpatrick will outline how the essential public health functions have been incorporated within the competency and outcomes framework. And finally, Laura Magana will provide the vision for and suggest mechanisms to support incorporating the essential public health functions into curricula. This will finally be followed by approximately 10 minutes that we will allow for question and answers at the end, which Priscilla Robinson will lead as the other co-chair of the Federation's PET working group and also co-host of this webinar. But firstly, to introduce my colleagues. So Ataya Masam is a public health medical specialist with over 15 years of experience in health system strengthening initiatives, from national policy development to health management and implementation of interventions. Ataya has served on various executive committees, including as the Secretary of the Public Health Association of South Africa. She has co-led the roadmap's work on Action Area 1 in terms of revising the essential public health functions, and is also a member of the Technical Advisory Group on Competency-Based Education. Siobhan Fitzpatrick is a technical officer in the Health Workforce Department at the World Health Organization in Geneva. Siobhan's led the development of the Competency and Outcomes Framework and provides the Secretariat to the Technical Advisory Group on Competency-Based Education. She previously led the development of the WHO Global Competency and Outcomes Framework for universal health coverage. Laura Magaglia is President and Chief Executive Officer of the Association of Schools and Programs of Public Health, or ASF in Americas, and is also the founding president of GNAF. Under her leadership, ASF has continued to advance academic public health by mobilising the collective power of its members to drive excellence and innovation in education, research and practice. Laura has co-chaired the Technical Advisory Group on Competency-Based Education. And Priscilla Robinson is co-chair of the Federation's PET Working Group and is also a director for the International Health and Epidemiology for the Guidelines and Economists Network. Her work in public health practice, teaching and research spans some 5 decades of work that has crossed Australia, Papua New Guinea and the United Kingdom. Priscilla also co-chaired the work of the Technical Advisory Group on Competency-Based Education. So with no further ado, Ataya, I will hand over to you to start speaking about your area of work. Thank you.
Thank you, Leanne. Let me bring up my presentation. Are you able to see it on your end?
Yeah.
Okay, great. Good afternoon, good morning, good evening, everyone. As Leanne has kindly introduced me, my name is Dr. Ataya Mossam. I am from the College of Public Health Medicine in South Africa, and I am the co-chair of Action Area 1 within the WHO Roadmap on Public Health and Emergency Workforce. So, and now, okay, there we go. So within the WHO roadmap, there are the 3 action areas which Leanne has gone through briefly, but to see them visually, I think helps to concretize that these 3 action areas are really interdependent and related, and are not meant to be hierarchical. But however, the work of Action Area 1, which is around defining the essential public health functions and services, really does underpin a lot of the work in the other 2 action areas. And that's a rationale for me preceding my 2 colleagues today, so that you have a sense of what these essential public health functions are when we speak about them. So really the work of our action area was to ensure that we had a technical package that consisted of a range of flexible and adaptable tools to support the comprehensive operationalization of public health in countries. Even though this is a framework or set of tools, it is adaptable to different contexts. What this technical package consists of is the unified list of 12 essential public health functions and their 48 associated sub-functions, a defined package of 20 public health services and 12 system enablers, which I will go through in short course, and then an approach to rapidly establish a baseline in order to deliver these essential public health functions. So what exactly are essential public health functions? These are a set of fundamental, interconnected, and interdependent activities, which are both within and beyond the health sector, that are required to ensure effective public health action for disease prevention, promotion of health, and protection of health. Now, I know many of us would default to thinking of this as critical to health security and resilient health systems, which it is important to, but it also provides the basis for improving public health practice towards universal health coverage, which really is the mainstay of our day-to-day work as public health professionals. So I know many of you are probably thinking, oh gosh, not another framework. And how does this articulate with other frameworks? But I assure you that there really is synergy between these frameworks and efforts towards universal health coverage and health security focus efforts. So if you look at the slide in front of you, you can see in the center, there are the essential public health functions that have been listed. And then there are efforts or frameworks related to universal health coverage, such as the health system framework, which we all know very well, but also the PHC operational framework. On the right-hand side, there are frameworks related to health security efforts, so the international health regulations and health emergency and disaster risk management. Now, my colleagues have very kindly color coordinated this, so it is visually very easy for us to see that there is synergy across these frameworks. And you can see that most of the essential public health functions are represented in the other frameworks. Specifically in relation to today's discussion, you can see that health workforce is represented in all of these different frameworks or approaches and is really central to delivering on the essential public health functions. So what exactly are these essential public health functions that we need to name? So there are 12, as I've stated, that sit in 3 buckets. The first is around cross-cutting functions, and I think many will agree that EPHF1, which is around public health surveillance and monitoring, really underpins all of our decision-making and what we decide to do in terms of public health. On the left-hand side, you can see the EPHFs that are related quite specifically to public health service orientation. So these include public health emergency management, but also health protection, prevention, and health promotion that happen within emergencies and in the due course of our work. On the right-hand side in yellow, you can see the system inputs and enabling functions that very much approximate, again, our health systems framework. So looking at things such as stewardship, planning and financing, community engagement, workforce development, health service quality, public health research and knowledge, and access to technologies and products. So these 12 encapsulate the 12 essential public health functions and their associated subfunctions. So what was done to unpack this? A series of consultative and approaches was done to ensure that we unpack these EPHFs towards an operationalization of them. The first was to look at each of these 12 EPHFs and unpack them in terms of subfunctions. What subfunctions would contribute towards the achievement of an essential public health function? And then there was further unpacking to look at what public health services would need to be in place in order to achieve these subfunctions, and what system enablers would assist the public health services to work in a framework that it was efficient and achievable. So in terms of activities, public health services, when we talk about public health services, we're really talking about activities where the primary focus is on population level impact, but it also has an impact on reducing the risks and promoting health at an individual level. So if we look at public health services that reflect a wide range of activities that really address the broader determinants of health. So for example, policy and legislation or health programs, and maybe nested both within the health sector or outside of the health sector. When we talk about system enablers, this is literally looking at infrastructure, institutional arrangements, resources, or mechanisms that support integration and multi-sectoral capacity development and delivery of these public health services. So what was done was, as I've said, the EPHFs were unpacked into the subfunctions, the public health services, and the system enablers. And as you can imagine, there was a considerable amount of overlap and synergy between and within these subfunctions, between and within the public health services and within the system enablers. And so the work really was to tease out where that overlap occurred and to really consolidate these into a package of services that could be consolidated to apply to different subfunctions or different essential public health functions. So what does this look like practically? If you look on the left-hand side, you can see there are 3 EPHF listed. The first is around public health surveillance and monitoring, the second around public health emergency management, and the third around health protection. Now, within the center of the slide, you can see the public health services that were unpacked for each of these EPHFs. So EPHF1 talks about a public health service related to ongoing and systematic surveillance of public health data, including population health, health-related behaviors, etc., but also a service related to synthesis of available evidence. If you look at the services related to EPHF2, again, you see ongoing and systematic monitoring and evaluation of health systems, but including incident responses and communications, amongst other services that could be possible. And in terms of EPHF 5, health protection, you can see again, we have ongoing and systematic surveillance of public health data, including health-related behaviors, disease incidence and prevalence, but also services related to development and implementation of programs, or again, communication between stakeholders. So as you can see, those three EPHFs all talk about integrated and ongoing systematic surveillance. And so the work really was, how do we consolidate those into one public health service that could talk to all three of the EPHFs without being needlessly complicated. So that led to the first block on the top right-hand corner, you can see that says, ongoing and systematic surveillance and monitoring of public health data, including population health status, health-related behaviors, disease incidence and prevalence, health risks and hazards, protection and protection factors, which really takes all of those different EPHF public health services into account and consolidates them into one. So what are these public health services? I'm not going to go through each and every one of them, but there are 20 of them that cut across the different EPHFs. So EPHF 1, 5, 6, and 7, which are related to public health surveillance, health protection, disease prevention, and health promotion, have their own associated public health services, which are related to them specifically. But you can see that there are also cross-cutting services that relate to the ones that listed above, but as well to all of the other EPHFs that are listed within the framework of 12. Additionally, you can see that there is the package of system enablers. Again, I'm not going to read this entire slide, it's quite busy, but I have highlighted some of the areas which I think make it easy to understand how this actually relates again back to the health systems frameworks that we know. So these system enablers consist of, for example, legislative, regulatory, and policy frameworks, governance structures, multi-sectoral approaches, participation of communities, information systems, public health workforce, financial resources, delivery platforms, infrastructure, monitoring and evaluation, essential medicines, and public health knowledge and policy. So I know I've said a whole lot of things. I'm going to show you exactly practically how this articulates together. So if we take EPHF 6, which is the EPHF around disease prevention, you can see on the left-hand side, the description of this states that this activity involves the means, processes, and actions that support the prevention and early detection of communicable and non-communicable diseases, including mental health, in defined and targeted positions, and it typically involves primary, secondary, and tertiary prevention. Now, this EPHF, as I've said, has been unpacked into its subfunctions. It has 3 subfunctions. 6.1 is related to designing, implementing an MNE for interventions, programs, and services for primary, secondary, and tertiary prevention. It's quite a mouthful. Subfunction 6.2 talks about integration of prevention and early detection into service delivery. And then subfunction 6.3 talks about partners to support the development and MNE of policies and programs to reduce risk factors. Now, if we take, for example, the health services into account, you can see there are 3 public health services, and I know this is quite small, but I'm going to take you through it. There are 3 public health services that are quite specific to disease prevention. They have been allocated to that EPHF, and this relates to primary prevention, early identification and appropriate management, and then minimizing disease progression, complications, or impacts. So these are quite specifically related to EPHF 6, but are also quite specifically related to subfunction 6.1. If I had to give you an example of what these public health services could be, the primary prevention service could be, for example, the development of a national immunization guideline, for example, around HPV, if we take cancer as an example. The early identification and appropriate management could be around the development of national cancer control programs, for example, around early screening and detection of cervical cancer. And then if we look at the minimizing disease progression, complications, or impacts, the activity or public health service there could be ensuring access to palliative care. Now, these 3 public health services, as I've said, are quite specifically related to EPHF 6, but then there are other public health services within the cross-cutting bucket that may also be related to EPHF 6. So if you look at subfunction 6.2, which talks about integration into service delivery, you can see that there is a public health service which is related to working with partners to ensure high quality health services. In the context, again, of cancer, this could mean monitoring of health service utilization and access to ensure that women, for example, are accessing pap smears and cervical cancer screening programs. If you look at 6.3, it talks again about working with partners to support legislation to reduce risk factors. And again, there's a public health service related to that. And this could be, for example, practically a defined minimum list of services, including public health services, again, around maybe potentially HPV services and in terms of immunization and screening, that all regional services or local health authorities would need to deliver. So that is a very practical way of seeing how one EPHF could be unpacked into its components. In addition, as we've said, there are system enablers. And so I haven't put all of the system enablers there, but the two that really specifically relate to the EPHF 6 could be the legislation, regulation, and policy, and monitoring and evaluation. And so this is a snapshot of how all of these different areas within the EPHF package articulate together. So what does this mean? This really is a call to collaborate, to use the technical package. It really can inform you and your governments to identify strengths and gaps in your public health capacities in order to inform policy and planning. You can strengthen your institutional structures for delivery of the EPHFs. It will allow for defining of a comprehensive public health package in a national context, within the national context. It will allow for strengthening of promotive, protective, and preventative capacities of health in the allied sectors. And then finally, and this is where I now hand over to my colleagues to talk about strengthening of the workforce capacity for delivery of the EPHFs through competency-based education. So finally, I'd just like to acknowledge my colleagues at the WHO, Dr. Suhail Sarkit and Dr. Sakit Mustafa, who really were the technical brains behind the work, as well as the wider steering committee and IANFI, who were involved in the consultative process around this work. Thank you so much, Leanne.
Thanks, Ataya. And Siobhan, I'll hand over to you.
Wonderful, thank you. And thank you so much, Ataya, for setting the scene very much on the work, the foundations of the WHO and partner roadmap to strengthen the workforce for the EPHFs. So I'm going back a slide. So the competency-based education aspect, how do we strengthen the education of the workforce to enable them to deliver on those EPHFs? So the work that I'm able to share with you today, it's in a pre-final form, so we are able to share advanced insight into the competency and outcomes framework that has been developed and prepared by partners over the last 12 to 18 months. So we have developed a competency and outcomes framework to guide the strengthening of curricula, so to define the outcomes of curricula, but also the process through which competency-based education is designed and delivered effectively. Competency-based education is, of course, an extremely effective way of strengthening, of preparing the workforce, because it is rooted in the outcomes that are relevant for employment. So we're very much thinking about the contributions of individuals to those essential public health functions, which, as we've seen from that previous presentation, are very high level there for the system, for a whole country, for a whole workforce to provide and deliver on. So when we start to work backwards from those 12 essential public health functions, we've heard from how these can be then deconstructed into what are the sub-functions, the services, the enabling services. And really what we are focusing on in the competency-based education approach is what are the tasks of individual workers towards those EPHFs. So of course, in the same way that those EPHFs are interrelated, we can find that sort of a lot of the tasks are interrelated. So we don't have somebody who their whole job is health protection, because of course that interacts with disease prevention, with emergencies preparedness. So we're very much looking at those EPHFs in the round and then trying to identify what it is that individuals do towards those EPHFs. So the public health and emergency workforce, is enormous. It's all of us. So a lot of us, when we refer to the core public health personnel, so those health workers with specialized training or whose role is entirely around public health, but we also recognize that actually all clinical practitioners make a big contribution to public health through surveillance, through health promotion, or perhaps with specific responsibilities in public health as part of their clinical role. So that's the group on the left-hand side. The third group of the workforce that we talk about is also personnel from other allied occupations whose roles are particularly focused on the determinants of health. So this is everything from street cleaners or data analysts, or policymakers. So people who might not necessarily be identified as those core public health personnel, but we want to look at actually how do we ensure that the entire workforce is best prepared to deliver their tasks towards the EPHFs. So a couple of slides just to make sure that we are all talking the same language when we say competency-based education. What do we mean by that? And then I will be able to walk us through both the framework, but also how we developed that framework. So competency-based education, it's a whole of program approach. A competency framework helps to define the outcomes of a curriculum. And then when we are developing that curriculum, it's also about the progression of learning content. It's the learning experiences to enable learners to develop those outcomes. It's assessment of achievement of those outcomes. So where we start from health needs, health systems, and in this case, the essential public health functions and the services, sub-functions, enabling services, and then we tease out, so what is the contribution of individuals? So what are the outcomes of the education program that individual needs to do to perform their tasks for practice? And what are the competencies that they need to do so? And then from those outcomes, we can look at the content of the curriculum. The competency model that we have adopted with this framework is a holistic approach to competence. So we focus both on the practice activities, the groups of tasks that an individual will do in practice. So these are things that you might see in a job description or something that you could delegate to somebody else. But we know that the provision of public health services is so much more than a task list. We need people who are able to make effective decisions under pressure, collaborate in teams, draw from the evidence, communicate effectively. So these are the competencies of the individual, their behavioral, that enable effective performance of the practice activity. So when we're thinking about how best to prepare individuals for work, we need to think both about what it is they do and how they do it. What are the attributes of the individual? This, of course, is rooted in the very essential foundations of knowledge, skills, and attitudes. So very much when we're looking at the whole curriculum, we need to think about all of these different aspects together. And then last slide on the theory of competency-based education. When we think of competence, we're thinking about the outcomes of the program aligned with employment, but we know that learning is, of course, on a continuum and that different courses, different learners will be at different stages. So when we're defining curricular outcomes, we really need to think about what is the outcome of this program? Where will that learner be in their sort of learning journey? What is the teams they'll be working in? What are the level of supervision or the responsibilities? So developing a policy might be on a sort of institutional scale through to international scale. So there are different ways to think about that learning progression. Sorry, forgive me. So when we set about developing this competency and outcomes framework, we are not the first to do this. So we had a big task ahead of us, looking at the breadth of the workforce and the breadth of the public health functions. So we started from looking at what is already out there, and we identified more than 100 frameworks, existing frameworks on these different areas. So we had a scoping review, as well as web searches and through the expert network, to identify 125 existing competency frameworks. We also looked at guidelines, guidance, what are the policy documents and strategies around the different aspects of public health and emergencies. And then through looking at that existing content through the lens of that competency model, we started to organize the content into the different tasks, the different competencies, to identify the overlaps between the different occupational groups. So this was a very thorough process. There are huge spreadsheets with thousands of rows with the different tags looking at the content. So this was very much an iterative development. There was a research team. So it was the World Health Organization in partnership with NHS England, Health Education England at the time, Imperial College London. And we also worked with the support and supervision, the guidance of a global technical advisory group. And of course, all of the speakers on this webinar today were members and co-chairs of that technical advisory group. This work was part of the roadmap steering of the overall roadmap, which had its own steering committee. So again, this work was feeding into that overall roadmap and ensuring that we are very much aligned with, for example, the work to define the essential public health functions. We recognize that actually, sort of in line with good practice, even with that breadth of that global expert advisory group, we still needed to bring in perspectives from people in different countries, in different occupational groups and areas of work. And so we very much sought to involve a wide expert network in the consultation and validation. So, so this is just to acknowledge the members of that technical advisory group, and you will recognize some of the faces there. So 23 different members who provided that oversight throughout. And then when we look at, in addition to those 23 advisors and the research team, we also involved more than 140 different experts. So we actively sought that global distribution. Of course, we didn't quite achieve sort of equal regional distribution, but we did bring in perspectives from across the 6 WHO regions, as well as at different stages of their careers and in different professional backgrounds. And one that we can't say that we set out to achieve, but somehow we achieved a 50-50 gender balance, which across the different experts that we involved in this work. So there was an iterative process. Obviously, we started small, looking at the scope. What are the practice activities towards the EPHFs? And then with each iterative draft, we were able to validate, update feedback based on feedback through the different consultations, and expand iteratively. So the technical advisory group was very closely involved in conceptualizing and organizing the content, overseeing the research team. And then once there was a full first draft, that was when we opened the consultation to that wider expert group. So there were 3 drafts that were subject to global consultation. And as you can see along the bottom, in terms of the volume of impact, so we invited free text feedback to really capture the richness of feedback and insights, which we were able to integrate in successive drafts. So now I can share with you the content of the framework itself. So it is organized into 4 chapters. The first chapter covers the background, the methodology, the context of the EPHFs, and of course, principles of competency-based education. But what we're really interested in here are the competencies and the practice activities towards the EPHFs, and of course, the guidance, which is in chapter 4, on how to integrate those competencies and practice activities into curricula. So how to use the framework to guide and strengthen existing education programs or create new education programs. So actually flipping that content round, starting with the practice activities, because of course, when we start curricular design, we need to know what it is that somebody will be able to do on course completion. So this is we identified 40 practice activities organized into 5 domains, and this is for the breadth of the workforce. So for the entirety of those 12 EPHFs, and for the breadth of the core public health, clinical practitioners, and other occupational groups for whom public health is a part of their role, we identified 40 areas of work. And these were broadly organized into health systems, public health intelligence, from gathering information, acting on that information, public health programs and services, the management of resources, and also emergency management, from preparedness, risk management, risk response. So you have on the screen some examples of the practice activities. Of course, no individual can be responsible for a practice activity in entirety. So when developing curricula, it's important to then look at what within those practice activities is within the responsibility of an individual. So within the framework, we have then further elaborated example tasks. We've linked these back to the EPHFs and their subfunctions. There are illustrative profiles, an illustrative profile from each of those 3 occupational groups, but also at different career stages. So from an early career person through to a senior person with leadership and decision-making responsibilities to guide how to adapt from the framework. Of course, by definition, the framework is not standards, it's not authoritative, it's almost a menu of those different outcomes. There are also curricular guides exploring the different areas of knowledge and topics that would need to be covered within a curriculum that an individual would need to develop in order to be able to perform the tasks as part of their role responsibility. So there are 40 of these in the framework. One of the really interesting findings that we had when mapping the competencies, the behavioral attributes of individuals, is the commonality. So we identified that to deliver across those practice activities, that individuals need to have competencies that are community-centered, competencies for decision-making, effective communication, collaboration, be it with teams, with communities, with organizations, including organizations and actors outside of the health sector, interpreting and acting on evidence, and also their individual personal conduct. So in the framework, we identify 20 competencies, and we further elaborate, so how do we know if somebody has those competencies? What does it look like? And we elaborate on these in their behaviors that demonstrate those competencies. So the reason we started with the practice activities and then go to the competencies is these competencies enable the performance of practice activities, but they're also observed and assessed in the context of those practice activities. So we could not certify somebody as, you are an effective communicator. We need to know, what are your role responsibilities? Is that developing a public health campaign? Is that organizing a team meeting? Or is that collaborating with communities? And then once we have that practice activity for context, then we can start to see, what do those behaviors look like in practice? And then the final chapter of the framework is guidance for how to adapt from the framework, contextualize that, and bring that into curricular content. So again, going back to, this is a framework of outcomes, but we do elaborate actually some of the content and topic areas we would expect to see in curricula. So it's the competency-based outcomes that then guide the progression of content, the learning experiences assessment, and of course, the design and delivery of education to enable learners to develop those competencies for their practice activities. Thank you.
Thanks, Siobhan. And again, a nice segue now to you, Laura, to talk us through then, how do we consider all the complexities that both Ataya and Siobhan have been talking about in terms of the layering from the essential public health functions through to the competencies and practice activities? How do we then support education programs and institutions to put that into curriculum? So over to you, Laura. Thank you.
Thank you so much for the invitation. I'm just so honored and proud to be part of this incredible work. So thank you for my colleagues, esteemed colleagues that really have presented the whole roadmap. So in my role as president of the Global Network, which Leanne was saying, it is an alliance of the 7 regional associations of schools and programs around the world. We represent 500, a little bit more than 500 institutions and in more than 100 countries. And in that role, I have really the privilege of serving as co-chair of the technical advisory group guiding the work on action area number 2, which was just described. And Siobhan just discussed that it has been really an amazing journey. So I want to touch in right here. Why is all this work needed? We all know that the pandemic exposed the weaknesses of health systems worldwide. and has provided new impetus for strengthening health systems, revitalizing essential public health functions, and enhancing emergency preparedness and responses capabilities. It also reminds us of the interconnectedness of health, social, and economic systems. Strengthening health systems that address the social determinants of health requires a resilient public health workforce at the helm. That is why the global network of academic public health institutions is proudly supporting and working very closely with WHO and partners in preparing the workforce we need to address current and future challenges. In this regard, we strongly support the WHO roadmap because we believe it offers a blueprint for countries to assess themselves and develop action plans to build capacity of the workforce which delivers the essential public health functions. As a global network, we believe countries can learn from each other. And regionally, there can be increased collaboration to pool resources and expertise. This implementation can be enabled through evidence-based guidance and innovation and disruptive ways of thinking to reassess public health education, research, and practice. By establishing well-defined competencies for public health personnel, we can work in a more synchronized and effective manner to protect the public's health and improve confidence in times of misinformation and distrust. We need to address the entire continuum of education in order to integrate the essential public health functions. Traditionally, academic public health has focused on graduate level education to train future public health professionals. There are growing movements around the world to incorporate undergraduate education through associate and bachelor's degrees in public health. And we also work with the existing public health workforce to update their competencies and acquire, of course, new ones. This is currently the realm of schools and programs of public health. And this is where we need to be teaching about the essential public health functions. Once the final document is released, as Joan was saying, we very much are looking forward to start working on the stratification of the functions in this continuum. In other words, what are the functions that need to be taught in the undergraduate and graduate degrees? Or what is the depth of knowledge and practice we can expect in each academic level? The same is true for the workforce development. The roadmap offers extraordinary resources to make those decisions locally, nationally, and even regionally. And of course, we are already thinking that we need to incorporate Public Health 101 into K-12 education to produce educated citizens. The roadmap comes in a pivotal time for both fields, health and education. In the health side, we know that we need to raise preparedness, readiness, and workforce capabilities to perform the essential public health functions. And in the education side, in particular in higher education, we know we need a new social contract between higher education and learners. Our graduates in the digital economy no longer expect their jobs to represent a linear progression from 4 years of college into a single position that never changes. They instead expect their current job or career at some point to evolve, forcing them to prepare with new competencies and unpredictable moments throughout their lives in a world shaped by globalization, environmental crisis, and artificial intelligence. Learning and working merge into one entity to the rest of our lives. So we have a great opportunity to embed the essential functions in all the public health workforce training that's happening as a result of this trend. Job transitions have become an established part of life. Workers now experience at least 12 job changes by the time they retire and stay in the workforce at historical high rates into the late 60s and 70s. Through the lenses of human longevity, work becomes inextricably tied to education. The average lifespan of children born in 2020 is projected to be 90 to 100 years. Many will need to work until mid-70s in order to have enough savings for retirement. The 60-year curriculum coined by Gary Matlin refers to a new perspective oriented toward continuing education and centered on 6 decades of employment, requiring a lifetime of learning in the context of repeated occupational change and transition. So the social contract between higher education and learners will be expanded for the rest of their lives. I hope all the educational institutions around the world are already transforming their infrastructure accordingly. So periodic returns to learning are the new normal. There will need to be more on and off ramps for long life learning. We'll need to harness the power of education gaining that we need and seamlessly re-entering the workforce highway. So this is particularly important for the public health workforce, where the needs and priorities of population's health are constantly changing, and the workforce is in need of constant updating their competencies. Besides the fact that there are so many public health workers that don't have a degree or training in public health, as Jovan was referring. So learning and working are becoming inseparable indeed. So this is precisely what it means to have a knowledge economy or a learning society. It follows that if work is becoming learning, then learning needs to become work. And universities need to become living systems to open, encourage, and promote flexible possibilities. That is why the roadmap provides not only the competencies that the workforce need to have, but the practice activities. So this constitutes a very practical approach to describing what needs to happen in the field so workers can be specifically trained. A great advancement of the roadmap is that it's not a list of content areas that the public health workforce need to perform, but rather it's a competency-based document where competencies are grouped on categories, describing what a competent workforce looks like as it relates to knowledge, skills, and attitudes. Public health education has finally got to the realization that we need more than the technical and expert knowledge, but we increasingly require more cross-cutting, professional, soft competencies to deal with uncertainty and ever-changing priorities. We need to focus on essential competencies like using big data, problem solving, interpersonal skills, cultural agility, and others that will allow the workforce to face the challenges of today and adapt those of tomorrow. Public health competencies will continue to develop as technical innovation disrupts existing jobs and creates new jobs. 50% of current jobs will actually disappear in the next decade and be replaced with new ones that we couldn't imagine. So we must develop new ways of defining, developing, and assessing integrative competence associated with education for life. So education in public health around the globe is thinking more in a holistic, balanced curriculum that better equip our students. So at least we are thinking about that we have on all the curriculums to have cognitive and metacognitive competencies such as creativity, autonomy, strategic and critical thinking, the social and emotional competencies like empathy, collaboration, resilience, respect, appreciation for diversity, and of course the technical and professional competencies that we all need in our careers. So we must equip students for the world that is actually it is building in our eyes. And graduates with this approach will have then the tools to really start their path like in the future. So these are exactly the type of competencies that are needed to carry out the essential public health functions. And as Jovan previously reviewed, this document is really extensive. It covers all the 3 areas of the type of competencies we are actually embracing and encouraging. We are also know that we need to embrace hybrid models in order to teach these functions. Our world has already adopted hybrid environments for work, for recreation, and of course, to educate our learners. So when we think about including the competencies to deliver the essential function of public health, we need to be creative and innovative, embracing online, in-person, hybrid, mixed methods. Virtual learning can be great for gaining technical and cognitive competencies, whereas in-person instruction can experience are best for building social and emotional competencies. So beyond models, the most important thing is the learning methodology, where we continue to stress the importance of active learning. Learners need to be engaged in their processes in order to really master all the competencies. The future will lie in the diversity of models and teaching schemas. Higher demand for work-related courses, greater demand for virtual courses, blended models. All these educational models are suitable to develop the competencies to master the essential public health functions. So the health departments around the world and the public health schools and programs need to really work together in order to provide not just degrees, but also micro-credentials, short online courses, digital certifications in order to keep updating our workforce. In order to ensure the competencies the workforce that the workforce needs, they need to be incorporated, of course, into our curriculum. And we need to focus on two very important areas. One is accreditation. In the accreditation of schools and programs of public health, and in the area of practice and workforce, we need to concentrate also in credentialing. So accreditation assures the quality in public health education by accrediting programs and institutions. And we need to advocate to get the competencies we need, and we just review with my colleagues. All those competencies have to be integrated into the curriculums, and as I said, in the undergraduate and the graduate education, in order to ensure that all our students and the graduates are gonna already graduate with all these skills. But with the workforce that we have right now, we must not forget that we need to keep on updating them. And one of the ways that we could be very effective is in order to support really credentialing in the workforce. We need to ask that all our workforce has to have the competencies to ensure that they are really prepared and all our populations are going to be safe in terms of the current and future challenges. So credentialing of the current workforce is really another way to ensure that they have the knowledge and the skills needed to meet the needs of the populations. And all of this work that has been just presented here has to be incorporated also into the credential systems around the world. So with that, I just want to say that the WHO roadmap is really an important tool to help train the public health workforce to implement the essential public health functions. And we're so looking forward, all the schools and programs around the world, in order to implement this extraordinary work. Thank you.
Well, thank you very much. We've heard from three wonderful women, and to keep going with the W analogy, we seem to be on quite a wild ride for quite a lot of this morning. So thank you very much, the three of you, for your wonderful contribution. We have a very, very short time left. Originally, we'd hoped to have some time for questions. Before I summarize what's been said, can I just say that anybody that has any questions, please put them in the chat now. And if we don't get to them now, then we'll be happy to answer them over the next couple of days. So don't feel that when this closes in 5 minutes time, that's the end of it for you. So just to summarize what we've heard about, and it is a very short summary because we have heard about an awful lot. Ataya told us about the very, very complicated process of revisiting the essential public health functions and how they've been revisited and unpacked and where they've got to. And then Siobhan has told us about how the essential public health functions have then been taken and configured into education programs, but also starting with what competencies people need to have and going backwards to educational content rather than the usual educational process, deciding what people need to know and then delivering a program based on that, which is very unlike most educational programs that we have. So, and that's been such a very complex process, and the documents that accompany it are also very complex. And then Laura has told us or reminded us about the interconnectedness of health and education and security, and the way that the one thing doesn't happen, no one thing happens without the contribution and effect of others of these areas. And she's reminded us about the continuum of education. Laura, as someone who's kind of approaching their 7th decade, I really can I stop sometime? But anyway, but no, lifelong learning is a really important component of living in our world today, no matter how young or how old you are. So thank you for reminding us about that. And Siobhan, thank you for just saying that health is so much more and education is so much more than just a list of tasks. So with that, I'm just about to post in the chat the link to the roadmap program, if I can actually make it work. Save it. The link to the roadmap documents, which doesn't seem to want to happen right now. Oh, there it is. So, so I've just put up the link in the chat for people who are not familiar with where the roadmap documents are. The roadmap website is enormous and has an enormous list of resources, and the list of resources continues beyond that list of resources to people like us as well. So for people who are attending, do feel free to contact us and to pose questions. So we've now got about 3 minutes before we have to close, but I can't currently see any questions. Oh, maybe there's one in there. Let me just have a look at 2 questions. Let me just see what they say. Ricken Barrea wants to know where can she can get more opportunity for jobs in public health. Ricken, I suppose my initial answer to that would be, if you look at the area 3, action area 3 for the roadmap, it gives you a good idea about the breadth of public health opportunities, and maybe the documents that are produced by action area 3 might give you some good places to start. And I might just take the chair's privilege of answering that question myself. So I hope that's helpful, but if you have trouble, please just email us and we'll come back to it. How can the competency, L-Shake wants to know, how can the competency approach to link the academic tradition of the largely theoretical public health education? What could be the practical mechanisms for resolving these challenges, especially in relation to influencing academic leadership and faculty development to suit the competency-based approach? L-Shake, you have asked Siobhan's $90 million question, and it's something we're all grappling with, exactly how we can persuade our faculties to completely rethink how this happens. Siobhan, would you like to jump in there? And then the other panelists can have a go at that, because that really is the $40,000 question that L-Shake has posed.
Sure, absolutely. And I think this is exactly it. We know that this is what is most effective. We know that this works. So actually it's are the students driving through their choices? Are employers valuing what is coming out, the competencies and the learning that current graduates have? So what are the gaps, and where is competency-based education? How is that part of the solution? So we're not trying to do this for the sake of it, but actually if we can help identify what this offers within individual programs and link that to to employment, to students, and actually to how that would benefit then individual programs and institutions, then I think it's more about winning hearts and minds than about generating the evidence for it, because we know that this works and this is what we're looking to do. I know, Laura, you will be able to add to this, but Atia, I noticed that you have wanted to come in on this, so I'll hand first to Atia.
Thanks, Siobhan. I actually wanted to just tackle both sort of questions about like, where can I find a job, but also how do we make it practical? And I think the issue is that a lot of, as one of the attendees is saying, that a lot of the public health training is very much theoretical based, and a lot of people don't understand how to translate that into an actual job when they leave if they don't have a clear career path. And so I know there was some work being done in the UK around providing internships for, masters in public health students who may not necessarily be working in public health, but need to figure out a way to bridge that gap, because it's becoming a chicken and egg situation where I can't get experience to be able to do the work until someone gives me a job, but no one will give me a job until I have experience. And I really like what Siobhan was, the diagram around how training gets you so far, and then it's experience that really makes you an expert. And I think we need to think about that, but like, what are the practical avenues that need to be undertaken in order to give people that experience on the ground? Again, nothing that I know the solution to immediately. Thanks. Over to Laura.
Just 1 minute, just to say that I think it's just time to break the silos. We are a very silo profession, and practice do their job, and the graduate schools do their job, and the undergraduate do their job. And I think that Siobhan, when you talk about the whole process, it was a great example of coming all together: the practice, the accreditors, the schools, the students, the alumni, the young professionals, and come together in the same room trying to define this job. So that's exactly what we need to do now in our own countries, in our own regions. Is just we need to bring everyone together to do this job. And I think it's the perfect time right now before it's just too late that we lost the momentum in order to really get together everyone and try to have these discussions and have a comprehensive workforce development plan for our countries and our regions where all our voices are heard. So I just think it's about coming together. Thank you.
Thank you. Thank you, Laura. And Rick, and I think some comments that Laura made earlier about making sure that the degrees that students do are accredited, and the credentialing or registration of public health professionals means that only people who are credentialed can do public health work. And that will make a big difference in the future. So that's something we're very mindful of and we're doing our best to work towards. And Elsheikh, so many universities have silly phrases on their websites like our students will be job ready. This is a mechanism by which we can make sure that our students are in fact job ready. With that, I'm very aware of the fact that we're now 2 minutes over our allocated time. So please can I encourage anybody listening to text the Federation or text one of us any questions or queries you may have. And can I please say thank you to our three panelists once again for a terrific session, and hand back to Leanne to close.
Thanks, Priscilla. And I just want to echo my thanks to the whole team. I started off by saying that this all came about because of the partnership between our various organisations that we represent, and I think we've very clearly demonstrated that the work that has been undertaken needed to be done in partnership to bring all those pieces of the puzzle together. But equally, we need to keep working in partnership again to move this forward. It's not just about health, it's not just about education, it's about the workforce, it's about the employers, it's about the association, it's about our public's health across the globe. So as practitioners, as educators, as health professionals, I would encourage us to keep those collaborations going, and so also echo the invitation that Priscilla has opened up for you to contact any of us about any of this work moving forward. But thank you again to the panelists for joining us, and thank you all for joining us for this webinar, and we wish you all well. Thank you.